So honestly, you have to do the research. You have to sit down and
So
research.
the thing that we're going to talk about, and it doesn't necessarily take a long time, is the title is which neurovascular structure is it? And really it doesn't matter. So no matter what you do and no matter what you've learned, you've had people tell you that when you're working this way or when you're working here, you're affecting this, that, or the other, right? That's a fairly common thing to hear. The simple question would be, how do you know? How can you observe it and how can you be sure that that's it? So have any of you experienced when people are saying that they're specifically doing something to the vagus nerve? Have you seen this? You've heard of it. Yeah. Everything's the psoas and everything's the vagus and everything's the QL. You've heard this, right? So superficially, if I was to attempt to do something to the vagus, where would you suspect my hands should be? Sure. Yeah. Any ideas? So, and don't worry about it. Like, there's no grades here. It's okay.
I've seen this stuff.
Yeah.
And I've seen this stuff.
Who have you seen do this?
I don't know. I just picked it up.
Okay. There's a specific population that will do that for a very specific reason. It's paramedics. So paramedics, I believe it is when there is some kind of cardiac event, they'll do vagal stimulation. So they go mastoid process and they go nuts. Like, I mean, they go mean.
Where I picked it up is Ken Kanakin's PTSD with
Nice.
the dolphin neurostim here.
Mm-hmm. So there's assumptions there. The assumption is that if I put something on your tummy and if I put something at your mastoid process or at the top of the SCM, that I must be connecting the entirety of the vagus nerve with no understanding or no acknowledgement of how deep it is, how varied its path could be, individual to individual. But basically, most of the time, when you see somebody who you can trust doing something to the vagus nerve, they just go to the mastoid processes and they go like that. And that's paramedics during a cardiac event. You will definitely see people get down closer to the clavicle on the SCM because the recurrent laryngeal nerve, the recurrent laryngeal is only on one side. No, it's on both sides. It's just one side, it wraps around the carotid. But anyways, it comes back up. So like we're doing the recurrent laryngeal nerve. If you ever see anybody holding, so somebody's in supine and they just hold right here. If you have a heart rate monitor on them, you'll see it drop and then you'll see it go up and you'll see it drop and you'll see it go up. It's a term called vagal escape. So you can impact the heart rate if you just hold here, but it always floats back up, right? If it's a known phenomenon that it always floats back up, then you can start to question whether or not the method itself is doing what it says it does. So if I am very interested in saying I can help somebody's heart rate, which one of the measurements am I going to be interested in with the heart rate? Am I going to be interested in when it goes down or when it also goes back up? Which one am I going to talk about to people and say that I'm awesome about? When it goes down. Am I going to admit that it normally floats right back up? I'm probably not going to admit that. It doesn't benefit me to admit that. But it's a term called, as far as I know, it's called vagal escape. So it just floats right back up, right? There's a lot of things that can occur to things that you can measure that may not be meaningful. So my student in the room has done a thesis experiment. Have you ever heard of compression of the fourth ventricle, the cranial thing where they do this on the base of your skull, right? So they're claiming that by holding in the region of the occiput and not acknowledging that most of the occiput is covered by muscle, because the occiput's like way forwards, and what you can feel is it has to be above the superior nuchal line. Otherwise, you're feeling a bunch of muscle and dense muscle in every neck. So they're saying that on the outside of the skull, they're going to hold like a volleyball bump, and they're not going to touch your mastoids, but when you watch the videos, they're always touching the mastoids. And then they're going to follow the craniosacral flexion and compress the thing in your brain. And then, if they measure things, they're going to tell you it's because of exactly where their hands were, right? So I can tell you from my students' data that there is a positive impact on heart rate, aka the heart rate goes down. The blood pressure, so if you do mean arterial pressure, systolic and diastolic, and you run the formula, it goes down. Diastolic does better than systolic. Yeah, so diastolic improves better than systolic. You see that in a bunch of research that you would look at. Diastolic does better than systolic. It's like, well, why the heck is that? Like, what's really going on? Not 100% sure, but they're going to say for sure it's because of where their hands were. Now, one of my other students at my school did one in the neck. They did the same thing. They treated the neck based on whatever they found, and they ended up seeing similar things. The results were not as powerful, but it was the same direction. So Julia's experiment, sometimes in 2 of her participants, the heart rate went up. I think it was 2 participants, the diastolic pressure went up. Right? So blood pressure actually went up instead of down. So if I wanted to say that I have my hands here and I'm doing this and look, on average, it goes the right way. On average, it goes the right way. And her results look larger than the other results. They look larger, but they go in the same direction. The other student, she had no change on a few participants, but she didn't have any negative change. So depending on how I'm going to talk about this, which one would I be more interested in? Which one would I want to tell you about more? The one where it never went negative, right? Or the one where it looked bigger? So depending on what I'm talking about, where I put my hands. So if I say that I put my hands here and it's awesome, look at what it did. Or I put my hands on the neck and I say, look, it went the same way, right? Like it went the same way. I had similar results, maybe varying in not the intensity, there's a word, whatever. But it went in the direction that I wanted it to go, but maybe less so. Now I can go out and tell everybody, hey, look, we improved blood pressure. It's like, well, when did you measure it, right? Well, I measured it right after. Did you measure it half an hour after? Did you measure it a day after? No. All right, so if I wanted to say that CV4 does something specific to the vasomotor center, so have any of you heard of the vasomotor center? It's okay if you haven't. It's really not a thing anymore because people are much more aware that it's not really a thing. There is something in the cerebellum that has some systemic control over vascular caliber or the size of vessels generally, so it'll sort of open and close them. There is that in the cerebellum. The assumption is that when I do CV4, that's what I'm impacting. So if I'm impacting it when I put my hands under the skull, but I also impact it when I treat the neck, how powerful is what I say in one place versus the other? I have to say it's a different mechanism because it's in a different place, right? So if I'm using anatomy to explain my result, I must say it's a different thing, right? I must say that I had my hands on the base of the skull and I was compressing the 4th ventricle. Now, if I go down millimeters to the neck and I have a similar result, I have to say it's a different thing. Oh no, that's because of the carotid body and the vagus nerve. It's absolutely because of that, right? It's like, well, how do you know? If I see similar results, I have to actually acknowledge that it didn't matter as much where I put my hands. Now, at least in what my students have done so far, there is a difference that has value in investigating more. I have another student who is going to start to investigate what shoulder treatment does to heart rate and blood pressure, right? Now, the rationale there, what do you think the rationale for trying to say, okay, we saw one thing in the base of the skull, we saw one thing in the neck, they were similar. Now we're going to check in the shoulder. What do you think the point of that is? Like, what would we be trying to figure out if it is correct or not correct? If I talk about heart rate and blood pressure, because they're going to measure heart rate and blood pressure.
Any change that the client sees as a positive change is a positive outcome in blood pressure.
Sure. Now, they're not necessarily going to identify that properly in an absolute case. But what we're trying to do is build a map, generally speaking, of anywhere in the body where you have a mechanical change and its impact on heart rate and blood pressure. Because if it's the same in the shoulder as it is in the neck, does it matter where I go, right? Is it because of the location that I'm working? Everything okay?
Yeah.
Okay.
Sorry, I'm late.
No, don't worry about that. Late's no big deal. So if I can get a similar outcome by treating the shoulder for heart rate and blood pressure as I can in the neck, then can I say that where I treat matters? I can't. If, when I get into the shoulder, it's less powerful than in the neck, I can say, maybe it matters, but we have to actually figure that out. So the classic thing in many hands-on professions is that they'll say, if I go to this region of anatomy, this is what's going to happen. if I treat the neck, it's going to do this thing to this nerve and this thing to that nerve. Regardless of your training, most of you have probably experienced that, where it's like, okay, a good one is thoracic outlet syndrome, right? Thoracic outlet syndrome, where are the areas that you have to check to try to figure out where the actual compression is if you're only doing hands-on and you can't use anything else. You have no surgery available to you, you have no imaging available to you. Where do you have to go? Yeah, so scalene, pec minor, costoclavicular. When you say that, you mean SC?
In school they teach the clavicle and the first rib compressing.
Okay, so it's the, and how would you assess that? So the clavicle and first rib compressing, how were you taught to assess that?
Two tests, Edens and Allen's, I think it's
Okay, so Edens and Allen's, basically try to do this.
Do the compression
As
it works.
Yes, and then the treatment would be take the arm the opposite way.
Oh, that's the best thing about school. They don't bother to.
Oh, they just teach you the test? They don't teach you how to fix it? Okay, right on. Fair enough. Yeah, so the assumption is that the reason that somebody's having discomfort that would be described as a neurological discomfort down the arm is that it's compression in certain spots. So scalene, pec minor, clavicle, how do you check pec minor and not pec major?
You don't?
You don't?
Other than the fact that the testing doesn't really fully stretch pec major, so you're making the assumption that you're doing more for pec minor.
But how do you know it doesn't fully stretch?
Exactly.
Right, so it depends on the actual fiber direction of the particular individual, and you don't know that it's one way on one side and one way on the other. So I'm generally going to assume that the fiber direction of pec looks like this and this, right? I'm going to assume that. Have you looked at any pictures of dissections where you can see bilateral muscles? If you think about it, if you pull it up, they're not the same on the same person. So I have no choice but to make the assumption that, okay, so it's about here where they say it's mostly pec major, or pec minor, sorry?
Hyperabduction.
Yeah, like all the way up. It's like, okay, so the sternocostal head of pec major is not fully stretched. Like, what are we talking about? Yeah. So the challenge becomes you have no choice but to make assumptions on stuff you cannot observe. If you can't observe it, you can't meaningfully be accurate about it. You can do your best, but you can't meaningfully be accurate about it. So there's particular areas that people tell you about thoracic outlet syndrome. Have any of you had the experience of attempting to treat somebody who presents with thoracic outlet syndrome, and you go to the places you're supposed to go, and it doesn't do a damn thing? Yeah. Is it because you haven't had somebody with thoracic outlet syndrome, or because you get it every time?
Because I don't do like you guys. So that is
That's
why
fine.
I come to these classes.
Perfect.
So because it's just like one day they come like
Oh, yeah. So it's because you're in a situation where people are going to be coming and going from the resort. Right. You don't really get continuity of care. Yes. And the people who come to you are not coming to you with, say, complaints. Right. They just like, listen, I'm stressed. I came to another country because when I go to another country, everything gets better. It doesn't matter what's happening at home. Yeah. And then you're just,
You just have maybe the chops
right on.
tight or
right on.
feet.
And everybody, the traps are tight because that's where they hold their emotions.
Yes.
Everybody. No, this is my pattern of,
Yeah.
it's like nothing happens to your legs.
Yeah. So that is why.
Perfect. So what I will say is that the assumption of thoracic outlet syndrome is that the pinch points are the things that matter. And there are no other possible locations of compression. And that it has to be compression. It has to be. That's the only way you get thoracic outlet syndrome. It's the only thing. Have you heard? Now, I ask a lot of questions to try to figure out where people are, because if I get certain nods and other like funny faces, I'm like, okay, well, I'm not going to do that. So how many of you are aware that there is now generally accepted 3 categories of pain type? Sort of?
I feel like I heard that,
Okay.
but I'm interested in...
Perfect. This is why I try to figure out where you guys are, as opposed to assuming. Okay. Something? Nothing?
No, it's
Totally fine.
Explain what it
This is why I ask. So you have nociceptive pain. Nociceptors as a term makes sense, correct? The nerve endings that will identify a noxious stimuli to tissue. So there's possible or actual damage to tissue. The nerve endings pick that up and send it up. Now, do you suspect that that nerve ending would be more often chemical or more often mechanically gated? Or possibly both? It could be both. It could be all of them. It could also be a thermoreceptor because burns, right? So there's multiple types of nerve endings that will sense noxious stimuli to tissue and send it up to be interpreted, right? So that's nociceptive pain. There's possible or actual damage to the tissue. You interpret it properly, and you have behavior that pulls away from that stimuli. You adjust your behavior. And then that would lead to what everybody loves to call compensation, right? Now, does compensation in your world often get used as a negative term? Like, oh, you're compensating, that's why. If you don't compensate, what are you going to do? You're going to fall over. More problems. Like, compensation is totally fine, especially when there is either an actual noxious or negative stimuli or when there is something else. So you have nociceptive pain, then you have neuropathic, that's the word, neuropathic pain. So you have the nerve endings that are sending a signal of pain up. So there's actual or possible tissue damage. Then we check for this and we don't have this. We don't have anything going on with the tissue. So the nerves are sending a signal. We can tell that the nerves are sending a signal. The person reports something. We check the nerve and the nerve has a pathology. Right? So then it's usually an inflamed nerve. It sends the signal up. So it's the same signal. Then the person then interprets it as pain. And that's going to lead to something that you would probably often call, or you would often suspect as a practitioner that it's up here. Right? It's like, I can't find anything wrong with you. You seem fine. You move fine. Your tissue's fine. I don't know why you're in pain. Right? And then when you send them to a physician who can check the nerves or a neurologist, like, oh, these nerves are a mess. Right? So then they would try to intervene there. Then they have the final one called nociplastic pain. This showed up in 2017 because they were trying to figure out, like, these people come in and they describe a sensation of pain. Their tissues are fine, their nerves are fine, they have pain. What the heck is that? So that's sort of an attempt to try to deal with fibromyalgia, right? We have no identifiable pathology that we can point at, but you report pain. So this is where we start to get into a place where I can explain the approach that we can take. If pain could be actual damage, it could be neural inflammation, or it could be nothing we can physically find. From my perspective, what's the only one I might be able to find, which is the only type I might be able to find? So possible or actual tissue damage, no tissue damage but neural problems, or literally nothing that I could identify, that anybody could identify with any form of technology. Which one of those three can I find as a hands-on practitioner, or might I be able to find? A proxy for it, and a proxy being something that points to another thing. The first one? Yeah, so possible or actual tissue damage. Now, what does possible or actual tissue damage look like? Or how does it present to me as the observer outside of you?
A scar, an adhesion.
Sure. The easiest, I prefer to zoom out as far as possible. No, heat, come on.
Like if it's like something acute.
No, not necessarily.
Postural change.
Maybe. What? There. So then why'd you play with me? It's fair. Yeah. So it's motion. So can you identify properly in a way that everybody would trust a neuropathology? You can't, right? You can identify something that is not moving as is expected or as compared to its opposite, or to its pair, rather. So if I say ouch, where do you expect my ouch? Which arm? You expect it on the right arm because it's getting restricted short of full range. What I will tell you is that people can come in like this, say ouch, leave, and say ouch. Right? It feels tight. Why does it feel tight? Because it gets to an end range where you get some stretch that is detected by varying mechanisms, mostly muscle spindles. It then sends a protective response to tighten it up, right? So there are things that we can sort of point to as likely proxies for what the heck is happening. But if they come in here and they say, ouch, and they leave and they say, ouch, it's tight, should I bother myself chasing, ouch, it's tight? No, I just shouldn't, because I can't trust it. I can't find it properly. A colloquial or flippant way that I say it is, I can't feel your feelings. I'd be feeling too many feelings. Right? So I have no idea what you're feeling. Now that said, we sort of come to a place where it's like, okay, we know that there's 3 different types of pain. The only thing that I might be able to find that sort of looks like what, when somebody complains, that I can sort of as a hands-on therapist find is possible nociceptive pain, which is really identified through motion. It either moves, right? It either moves or it doesn't. It either squishes or it doesn't. That's all I've got. That's all I have accessible to me. Which is then why I will make the claim that the neurovascular mechanism, like which piece of neurovascular anatomy, it doesn't matter. Because my assumption is that if there is a movement problem, there can be some form of abnormal pressure in any given area. So when I talk about the vasomotor center, it's the caliber of vessels throughout the body, but blood flow is locally auto-regulated. You've all pushed on somewhere, you've seen it change, and take your hand off and it changes back, right? So it's perfusion or flush. That's actually a term called vasomotion. So if you're exercising and you're using a particular area, right, and you do it enough, you get a pump, right? Well, more blood's going there, right? It's locally auto-regulated. You have to drive the blood pressure up because the muscle is getting tighter. Now that's more obvious. The argument that many people would make is that there's a more subtle thing. It's like, well, when it's in the funny position for too long, that's why you have heart disease. It's because this has been bent too long. It's heart disease. It's like, no, it's been bent too long. There's just changes in the tissue that's normal, right? So we are going to, or I am going to suggest that if you find a movement problem and you work on a movement problem, you're accurate. If you assume anything deeper than that, you have a problem, okay? Do any of you have a shoulder that's a little funny? No?
I have
Some
dislocated in the past 2 years.
in the past 2 years? Does it move good?
Seems to.
Seems to?
Just a little
Okay.
cringy in those areas.
Okay, fair enough. Any neurological sensation down that arm or no? Nothing?
There's swelling.
There's swelling?
The
Okay.
axillary area that
Okay.
I'm trying to figure out.
Okay.
I think I know what it is. but-
Sure.
Yeah, I don't know over.
What do you think it is?
I think it was left out of its socket for 4 hours.
Oh, fair enough.
And there's just been
Disruption to the vasculature.
damage.
Yeah, sure, fair enough.
I think that's why nobody can find it.
Well, yeah.
Because I'm getting assessed